Okay, we're going to pick up with part 2. I want to point out to you, this is a head. That's the nose right there, in case anybody was wondering where we're looking. This is actinic keratosis, pre-malignant, and it's associated with sun damage or solar elastosis. A lot of times it's as much felt as it is seen, where this rough, scaly, sometimes erythematous patch is felt. Poorly defined borders. There is an increased incidence in fair-skinned individuals and those that have had multiple sunburns, especially when they were younger. So it's sort of cumulative sun damage. Anywhere from 5 to 20% of the actinic keratosis can degenerate into a squamous cell carcinoma within about 10 years. The biggest problem is which one of those AKs is going to do it, and it's very hard to tell. Again, we look at prevention is better than trying to treat. So we'll look at sun block and block out. The diagnosis here is, again, as much seen as is felt. And if you're not sure, usually like a superficial shave will give you the diagnosis, whether it's AK, basal, or squamous cell. If there is a keratic horn, you do want to biopsy those because about 10% of patients with keratic horns can have squamous cell at the base. And a lot of times it's squamous cell in situ. The treatment for actinic keratosis, if it's localized, you can use cryosurgery, liquid nitrogen, or nitrous oxide probes. They do hurt, and so it's sort of limited by the extent. You can curettage them and feather, usually with anesthesia and a radiofrequency unit, but limited in terms of its scope. And then what you're going to do is more of a field block, and the two drugs that we typically use are factual, which is a cytostatic agent, and it causes enzyme inhibition, so that lights up the abnormal cells as well as the normal cells. And so you apply it until you get reddening, almost to the point of blistering, and then you need to stop and let the body take over and heal. Creates an inflammatory process which then walls off the damaged skin. The advantage is you can treat large numbers and large areas. The disadvantage is the redness and sometimes the pain. Actually, one of my behaviorists came in and I looked like he either got beat up or met a flamethrower because his cheeks, his chin, and his whole scalp was all red. I said, "Are you on AK treatment?" He goes, "Yeah, factual." And it looked horrible for about 4 weeks. The other drug that you can use is Immunoquad 5%, brand name Aldera. The package insert says twice a week for up to 16 weeks. You can use about 25 square centimeters. A lot of us use off-label 3 times a week for 4 weeks. Let the redness fade and see what we are. If we need to, you can repeat. It's sometimes a little bit easier. The nice thing about Immunoquad is that it lights up only the abnormal skin cells, so it's a little bit more targeted. And it used to be more expensive. Now, actually, you can get it fairly inexpensively compared to the factual. Sunscreens, we really look at most of the sunscreens that are commercially available fill out UVB, which causes sunburn, but doesn't fill out the UVA or filter out the UVA. So that's what causes the skin cancer and or wrinkles. So you want to use a combination product that has either zinc oxide, titanium oxide, or avobenzone. And that we look at this, the SPF factor is really for the UVB, not the UVA. So most of the time, if you look at an SPF of 30, you're blocking the majority of the UVA light, UVB light, but it's relative. When you get up into the higher numbers, you don't get an additional large amount. So if you look at an SPF 15 is 93% of the filtered out the UVB, and when you go to the SPF 50, it's 98%. So you gain a whole 5%. The problem with most of this is that we don't use enough of it or frequently enough. Even though it can be waterproof, it really should be applied every 2 hours, and you need at least an ounce, so 30 to 35 mLs to cover the entire body. And this is what you can end up with. Now, this woman has had this for quite some time, and when you asked her, how long have you had it? And she says, had what? You know, it's like, okay, but it arises either from thermal damage or actinic damage, and the thermal can be irradiation as well. So every now and again, you might find an unusually placed basal cell if somebody's had a radiation for a prior chemo, or in our elderly patients for thymic irradiation. Seen on sun-exposed areas, so the tops of the pinna, the back of the hands, people that have been exposed to lots of sun, so telephone linemen, farmers, those people may have an increased risk for basal cell or squamous cell. You can see this rapid growth with erosion, so you may get an ulceration with a raised edge border. The metastasis potential for squamous cell is really based both on size and location. When you get a tumor greater than 2 centimeters, it has an increased risk for metastasis, and if it's associated with mucous membrane, so around the lip, that areas are more high risk for metastasis. And so our treatment is really still excisional, and sometimes you can use chemotherapy if the patient doesn't tolerate or couldn't tolerate surgery. The smaller lesions, less than 2 centimeters, need at least a 4 to 6 millimeter margin. And so as you get bigger and bigger, the margins get bigger, close to 1 centimeter. So you have to take an awful big chunk out, and then have to figure out how to close that. That's where things like flaps and plasties come into play. If they're anywhere along what we call the H zone, which is this area in the face, kind of looks like the Hurley advertising, that kind of a lazy H, those patients often would require being sent to Mohs surgery to define the border before you do definitive closure, and also very cosmetically sparing. Now, this is probably the most common tumor that we see, basal cell, but we don't know how common. Why? Because it does not have to be reported to cancer registries. So there are estimates of, several million patients with basal cells. And the classic here is the telangiectatic vessels and the rolled edge with the pearly gray. This is where, if you use dermoscopy, you can magnify this tenfold, and you start to see those abnormal vessels. For those of it you do colposcopy, remember you're looking for curlicues and abnormal arborization and punctate vessels. You will see the same thing. And the nice thing about the dermoscope, it can help us predict, is that basal cell, squamous cell, especially useful in the non-melanotic skin cancers. The most common type is the nodular and the superficial spreading, and the least common is the morpheoform, and that's actually a good thing because morpheoforms are often missed because they almost look like a scar. But what they do is they have tumor invaginations that are under the epithelial area into the dermis, and this is also why you get the name for basal cell is called rodent cell ulcer. Imagine rodents running along the sewers underground. And these patients who have morpheoform really do recommend that they go to a Mohs surgery because the margins are much more extensive and appears just on the basis of the superficial skin. Treatment we talked about, you can use immunoquad in the non-H zone. A lot of times that can shrink down the tumor and then it makes your excision easier, or it can be treated definitively. In the patient that doesn't want to do that, you can do desiccation and curettage if they're small. So this patient tells you they have this lesion that kind of looks a little erupted, red, and you touch it and it bleeds just like that. This is a wart, cutaneous horn, squamous cell, or pyogenic granuloma. Pyogenic granuloma. And this is also a pyogenic granuloma. You see this vascular kind of yellowish lesion. When you see pyogenic granulomas, they really occur in 2 areas. They're on the hands or the face. They have the best blood supply, although occasionally you'll see it elsewhere depending on the blood supply, but most of the time they occur on the hands and the face. It's an acquired vascular lesion, and your treatment is excision with sharp curettage to eradicate all of that granulation tissue. If you leave any of the granuloma behind, it will recur. All right, a couple other rashes that we see that are fairly common. Impetigo, staph strep combination rash. Superficial, spreading often, but very contagious, can go through daycare centers. If you're in areas that are homeless, it can go through rapidly. And so you see these red areas with vesicles. They can become bullous. When that vesicle ruptures, we get this honey crust. So when somebody says, I have a bullous lesion on the face and it's honey crusted, you can pretty well bet that it's impetigo or one of the impetigo mimics. And the treatment here depends on location and the extent. If it's a little lesion here or there, you can use topical antibiotics like topical misoprostol ointment. If it's more extensive, things like dicloc, cephalosporins, erythromycin, and often with topical as well. You want to make sure that whoever's putting that on, that they wash their hands well. A couple other child diseases. Fifth disease. Why is it the fifth disease? Because it was the fifth virus characterized. In Europe, it's the fourth disease. I don't know why. But it's a Erythema infectiosum parvo B19 viral infection associated with a low-grade fever, sometimes malaise, and then usually as the fever starts to defervesce, they get this slapped cheek or lacy-like rash across the cheek and the malar area with perioral sparing. The major complications are arthralgias and sometimes a post-infection anemia and even going into red cell aplasia. Often associated too with more problematic effects in those patients that are HIV positive. The treatment here is recognizing what it is, and it goes away with time. Now, again, we talk about measles and we talk about rubella and rubeola. And why? Because we're seeing those outbreaks again with increasing problem with less and less vaccination rates. This is a paramyxovirus, if you will, measles over 3 C's, cough, coryza, conjunctivitis. It's not a really impressive rash, and somebody once described it as a measly type rash. It's morbilliform, it's kind of a brownish red. It's on the face and then spreads to the trunk and then out to the extremities. Again, more problematic as you can get pneumonia, encephalitis. In adults, you can even get it atypical, and there's a vesicular form as well. Again, we prevent it if we give the MMR. Here's that morbilliform rash mostly on the torso, and you see these Koplik spots, which are these little areas here that aren't all that impressive, but they are pathognomonic for measles. Rubella, again, a nondescript, really morbilliform type rash. Here it's associated with cervical and posterior auricular adenopathy. And there aren't a lot of things that cause posterior auricular adenopathy. You think of things like mono and a couple of other viruses, but this is associated with this upper respiratory type symptoms, headache, nausea, vomiting. It's a palpable petechia, so if you feel the rash, it's like about 120 grade sandpaper. And again, this starts a little bit unusual. It's on the face and then spreads outward to the limb. Some of the rashes go this way, this goes out that way. The concern here is first trimester congenital defects if somebody contracts it while they're pregnant. And then another rash that we see, Roseola Infantum, herpes human virus type 6. Usually the history is it's a 6 to 18-month-old child. They have a high fever, 102, 103, about 2 or 3 days. The fever defervesces, then the rash comes out, and then mom brings the kid in. What's the rash? And it's a macular papular rash. It's, again, treated with a tincture of thyme. The big concern here is these have an increased association with febrile seizures. Scarlet fever, another common rash, which is really nice because when you can diagnose that, you know you've got a strep throat. It's caused by an extra bit of DNA coding for a toxin, and which causes this rash. And again, this is a palpable purpura as well. You can sometimes see sparing in the antecubital areas, so called Pastia's lines. You can get irritation into the tongue, so people call it a strawberry tongue. You can get post-streptococcal peeling. you can get post-streptococcal glomerulonephritis. The interesting thing about glomerulonephritis, it is irrespective of whether you treat the strep or not. It has to be with, again, more of an antigen antibody deposition than it is whether you treat or not treat, which is why in the certain parts of Europe, like Northern Europe and Scandinavia, they laugh at us when we jump to treat strep throat, because it doesn't decrease the rate of post-streptococcal glomerulonephritis, and nor does it actually decrease the rate of rheumatic heart disease. They are associated more with the type of the bacteria than it is whether you treat or not. We treat in the United States either with penicillin or erythromycin derivatives. This is your strawberry tongue. I guess that kind of looks a little bit like a strawberry if you look at the seeds here. And then you can see post-streptococcal desquamation as well. Not to confuse it with this one, which it sounds like it should be a snake. It's kind of an unusual, usually seen in infants. They can be pretty sick. It's scalded skin syndrome. It almost looks like this baby has a burn, but this is a staphylococcal infection. And you see that there's a fair amount of desquamation, usually under 5. Interestingly, it's a staph that has a toxin. The toxin codes for the scarlatiniform rash. And you also can get Nikolsky sign. So if you take this kid's skin, you will slough the epidermis off of the dermis. It's treated with antibiotics, but doesn't really change the skin rash. That's going to get better as the toxin wanes. It does, however, have a much better prognosis than toxic ectodermal necrolysis. Not all that common, but you don't want to miss it. Anybody see Kawasaki's disease this year? Kind of goes in cycles, doesn't it? This, again, you see a sort of a nondescript red rash on the face. You can see edema here on the bottoms of the feet. These kids can be pretty sick. It's an inflammatory vasculitis, and to make the diagnosis of Kawasaki's disease, you need to have 4 or 5 of the criteria. They have to have a high fever for greater than 5 days, and they need at least 4 of the following: conjunctivitis, strawberry tongue and fissures, erythematous rash, increased lymph nodes, or desquamation. The other name for this is actually the mucocutaneous lymphoid syndrome. So if you think of it that way, you can actually hit 3 of those points right there. These patients have increased ESRs and SED rates with an elevated white count, but also an elevated platelet count. They may get a platelet count in excess of 1 million. And these are associated with increased risk for coronary artery aneurysm. So our treatment is high-dose aspirin. You're talking 80 to 100 milligrams per kg per day through either day 14 or until they defervesce, and then lower dose aspirin plus IVIG. And then you have to follow these kids serially with repeat echocardiograms to make sure they haven't developed those coronary artery aneurysms. This probably is the most common rash I see, or spot, and if it's the most common benign skin tumor. If you look at that, the best way to describe an SK is somebody took some chewing gum and stuck it on your back. It's that stuck-on appearance. It can be any color, so it can be brown to gray to flesh-colored to black. And sort of the big concern here is, especially when they're darker pigmented or have a little bit of pigmentary change, is this a melanoma? And so you want to be familiar with this, because obviously I am not going to want to take out every one of those SKs. I trade a brown spot for a white scar or for a hyperpigmented scar, depending on the race. And so you really want to treat those that are irritated, inflamed, catch on clothing, catch on jewelry, and you need to put that in your note when you're doing the procedure, whether you're going to freeze it, cryo, or shave, because if you don't, it's cosmetic surgery and the patient gets stuck with the bill. So make sure those are the words you want to use: inflamed, irritated, stuck on clothing, stuck on jewelry. If the patient comes in and says, "Doc, I didn't have any of these things, and now I have hundreds of them," you may want to go looking a little bit more closely. They may have an internal malignancy. It's one of the signs of cutaneous manifestation for internal malignancy. The sign of lesser Tourette is this massive amount of SKs, often associated with tumors in the stomach. Tinea Corporis, another common rash. Classically described as ringworm. The problem is it doesn't come in rings and it isn't a worm, right? You see this central clearing with an advancing border. It may be irregular. It may not be nice and round like these are. If you want, skin scrape it, KOH it under microscopic. You will see the hyphae and the spores, and you can treat, depends on where it is located. If it's superficial, topical works. If it's deep-seated, so you're thinking palms, hand, hair, they're more likely to respond to a combination of oral medication. Tinea Corporis, again, jock itch by the location, often seen in the summer months in warmer climates. Usually topical, but if it's extensive or deep-seated, it may require oral as well. You can get what we call an id reaction from the fungus, so the body is creating, if you will, an inflammatory reaction, and so you may have a fungus one place, and you may have these sterile blistering areas on the palms or the fingers, and if you get concentrated on that and forget the rash, you have to treat the primary rash before the id reaction goes away. And a lot of these have a combination, when you get that, of using a couple weeks of an oral antifungal and 4 weeks of topical. You can see tinea versicolor, which is nice because it, again, has usually reddish, brown, white areas of pigmentation that are hyperpigmented and areas of pigmentation that are hypopigmented. It's caused by a superficial fungus, again, Malassezia furfur. The treatment here is either ketoconazole topical. You can use ketoconazole 1 dose. There's a bunch of other regimens. You can use Selsun Blue shampoo. We tell patients we control this. It'll come and it'll go. We see it more often in the summer as they try to tan, and you'll see areas of hypopigmented looking a little piebald-like. Okay, so we have a carrion. So you have to know what a carrion is. It's an inflammatory, boggy mass, and how do you treat it? Topical, oral, IV, potassium iodide. Oral. If you see a carrion like this boggy area, and you push on it, you get what looks like purulent material. The debate is whether that's infected with a secondary bacteria, or most of us like to think that's sterile inflammation. It's, if you will, a body's overexuberant reaction to the fungus at the base of the hair shaft. It's an inflammatory mass, and you really need to treat this with oral antifungals. And the treatments you can use griseofulvin if that's all you have. You could use terbinafine. You can use itraconazole. All of those work. The nice thing about their terbinafine is it's about half the length of the griseofulvin. But any one of those regimens work. We're going to finish up with Lyme disease, Erythema migrans, again associated with a tick bite. It's the Ixodes tick. It's smaller than the wood tick and often not noted to be even on the patient, and so they may come in with this spreading rash that gets bigger, and it may be quite extensive. They can be 60, 70 centimeters in diameter if it's left to fester. And then you have early and late phases, so you can get if you will, secondary and tertiary phases. The best treatment is obviously prevention, and you can treat this with things like doxycycline and erythromycin. If you avoid the tick, that's the best thing that you can treat. And then we'll just talk about one sexually transmitted disease because it's still on the rise. You will see both the primary chancre and then the secondary syphilis, which is this rash and it's on the palms and the feet. If you looked at that, and I'm going to magnify that, sometimes the mimic here is pityriasis rosea, except PR usually does not affect the soles of the feet. And I actually had a patient that I was convinced probably had pityriasis, and if I love it, patients tell you the diagnosis. He said, my partner said maybe I should be checked for syphilis. So we did, and he was positive. So luckily, I always wear gloves when I touch rashes like that, right? It's a spirochete. We get most of the time the painless chancre is often missed by the patient because it doesn't really bother them, but we'll see the secondary rash on the palms and the feet, associated lymphadenopathy, and if it's left unchecked, it can cause CNS or late cardiovascular effects as well. The treatment is, again, make the diagnosis with your antibody testing, RPR, or FTA-ABS. Actually, there's some new tests out that you actually do the FTA-ABS first, and then the RPR. Talk to your lab as to which protocol they're using. And we treat with penicillins, usually things like Rocephin, or doxycycline, or benzocaine penicillins. You can get a post-treatment rash, myalgias, and arthralgias and chills. This is the Jarisch-Huxamer reaction.